discussion. Pam?
Thank you, Phil. I represent both the provider community, and I truly believe nurses across the country also represent consumer and patient advocacy. So those are the comments that I'll bring to you this morning. And I want to start out by talking about the fact that despite many of the efforts, despite the early work that was done in 1997 and then the subsequent report in 2003 coming from the IOM about children, we have really failed the vast majority of Americans in terms of end-of-life care. And I think we continue to see that. There are pockets of excellence, but moreover, there are probably more examples that we can all cite where patients' wishes were not honored or they were overturned. We have presentation of life-prolonging options of care with no real hope of recovery that only cause suffering and prolong inevitable death. And that's really not acceptable. We've not been able to master the discussion about fetal care. We don't necessarily have enough courageous providers who can talk with patients and families about palliative care yet, as well as achieving a natural death. So nursing is very concerned with stopping the suffering and making sure that we don't induce treatments that have no merit. And we all know these stories, and I think it's a paradox that we consider ourselves a very civilized society, yet we have so many people who die in a very uncivilized manner. So why do we need to reverse this trend? Well, one of the first reasons is that even though we are living longer, we are going to have a rapid rise in the number of people that are dying, particularly in the next 56 years. And just to share some data, ANA's economist Peter McManaman, who's in the office today, has done some analysis, and his work it shares with us, again, a perspective on the fact that we all know that there's lots of baby boomers. We all know that there's a great utilization of care at end of life. But right now we see about 2.4 million deaths per year, and about 1.5 million of those are Medicare beneficiaries. By 2029, the Medicare age deaths alone, so just in 14 years, will equal that 2.4 million. And in 2036, they will have doubled to about 3 million per year. And given all the holding constant of the non-age Medicare age populations, by 2071, we will actually double the total number of deaths in this country to about 4.8 million. So not only do we have a responsibility to service those who we typically think of now as the aging population that is the most vulnerable and in need of palliative and hospice care as well as those with chronic illness, we face an even larger number, an undaunting task. We also know that we continue to see high consumption of resources that, again, may be futile or only induce suffering or only prolong life. With the same number you heard earlier, about 17 or 18% of patients die in intensive care units, and over 75% die in either nursing homes or hospitals. Now, nursing has long worked to improve palliative and hospice care across many, many settings. The American Nurses Association works very closely with the Hospice and Palliative Care Nurses Association, and throughout our ranks we have many individuals that are engaged in research about end-of-life care issues, hospice and palliative care nursing, as well as educating today's providers and also collaborating with many organizations and, as I mentioned, certainly consumer groups. So as we look at the IOM report, and we're very pleased and commend the IOM on being able to issue this report at this time, we believe that there are a couple things that we want to bring to the group's attention. First is inclusiveness in language, and even though it may seem trivial, in the introduction of the statement, it says the Committee of Experts finds that improving the quality and availability of medical and social services for patients and their families could not only enhance quality of life through the end of life, but may also contribute to a more sustainable care system. We agree with this statement, but would respectfully remind everyone that the insertion of nursing care in that sentence is really an omission. I mean, it is not just medical and social services. Nursing care is a large cadre of services that are the services that reduce suffering, are the services that make sure that patient has the chocolate ice cream, that make sure that all of the pieces of the puzzle come together. So we certainly encourage that to be infused into the future dialogue. When we think about delivery of person-centered and family-oriented care, we know that professional nurses really, again, bring together the health, illness, social, and cultural aspects and really focus extensively on care coordination, which is really critical. We all, again, know our stories where we have failed patients. And I just share very quickly with you one from a nurse who was helping her sister, who finally put an end to, helped her put an end to saying yes to fetal care. And when they got back to her, she had terminal breast cancer, when they got back to her primary care physician, the response, and this is not a criticism of physicians, but the response is, oh, thank God somebody in the family made this happen. I think, again, underscoring the need to make sure that we have the communications going on and that we're able to say that palliative care is not giving up. Palliative care is a set of many other additional services. We really support the recommendations on professional education and development, particularly end-of-life care education occurring in an interprofessional setting. And let me just close my comments with, again, really focusing on the fact that these conversations have to focus on quality of life. It is really asking early on, upstream, in our primary care environments before people are sick, what is it that you would like your life to look like? I had a good friend who, a cardiologist who died in an unanticipated automobile accident in January. And as the family put out comments about his life, and thousands of people commented on his Caring Bridge site, what they shared was that he always had a saying, today would be a good day to die. And he had gone snowshoeing with his best friend that day. And the family really said, today would have been a good day to die if we had heard that from Steve. And I think our goal should be to make sure that every day a patient dies, it would be a good day to die.